What's up, guys, and welcome back to the podcast. So this week I was delighted to welcome on Dr. Ryan Foley from Integrated Kinetic Neurology. Now, this podcast alone, I wanted to jump on here before and just talk about, or give you kind of a pre-warning that there is parts of this that we really go into the weeds. So we really dig into, let's say, the mechanisms behind it, the neurology and how that's affecting people on a day-to-day, and then how it affects them in a rehab setting. And there's definitely some things that you might feel that you don't understand exactly what either myself or Ryan are talking about, but there is a light at the end of the tunnel in that we actually do come out and we at the, let's say, in the second half of the podcast, and we start tying all that together, and it's going to be a lot easier for you to pick up on that. But you need the stuff at the start to get a good understanding of what we talk about at the end. Okay, so extremely interesting podcast, one of my favorite ones I've done so far, and love to detail that Ryan's able to go into, an absolute expert in the field, and I'll be delighted if I could get him on again. So as I was saying, if you feel like you're a bit lost at some stage of this podcast, don't worry, it does come back around, and we will break it down, make it a lot easier for you. So that's everything, guys, and I hope you enjoyed. Okay, hi guys, and welcome back to the podcast. So today we have an excellent guest, and we have Dr. Ryan Foley from Integrated Kinetic Neurology, so IKN. So thank you so much for coming on, Ryan. First off, I'll let you introduce yourself. So where are you from? How did you get to where you are? And what is your thought process when it comes to rehab?
Yeah, thanks for having me, Robbie. It's a pleasure. And so, yeah, I'm a physiotherapist by trade. I suppose I went to the US to study originally got back in 2008 at this point now. I went over on a soccer scholarship to the US. I kind of used soccer to get me to the US originally, because I just wanted to, use that at least to study in some way. But I always wanted to stay connected in some way to sports. So originally I wanted to be a physiotherapist to work with sports teams, but then as I went through the educational system over there, and obviously went on your clinical placements over in the US as well, working with different demographics, I learned that I really had a really strong interest in working with people with chronic pain and more persistent pain issues, as opposed to your acute kind of sports injuries. I still see that in clinic today now, but it's the more persistent pain issues that really kind of interested me more, because they challenged me more so,
Yeah.
Yeah, I went through education over there. It was a 6-year program in the US. Then I worked in Manhattan for 2 years. Then visa issues came up, as I was telling you before. Then I decided to move back to Ireland and set up my own little clinic in the south of Ireland, in my hometown of Waterford. And in that time, I suppose during the 6-year program in school, you don't really learn too much about what kind of strategies are necessary to help someone get from A to B, get someone from their painful state into a pain-free state. You really just learn the basics and learn how not to hurt someone, but it's really in the years after school that you really pick up the approach that you're going to use in a clinical setting. And for me, I did a placement in school. It was my second last placement. I did it in a hospital setting, where I was working with clients with chronic pain, but also clients with who were working through rehab after an amputation, so lower limb amputations, upper limb amputations. And the overlap between working with clients with trying to retrain their ability to move with a prosthetic limb and clients with chronic pain, there was actually a huge overlap there. And I became really interested in how, especially prosthetists, the professionals, and actually construct the prosthetic limb, how they actually go about identifying what does a prosthetic limb need to express to allow the individual to move well in the real world. And really, when you're going about trying to identify what kind of properties does a prosthetic limb need to express to allow an amputee to walk well, or to move well, to reach well, what you have to do is you have to study able-bodied movement, or individuals that don't have an amputation, obviously, right? And you need to look at their movement, not only from a standpoint of how do they move, but what is the interaction between the nervous system, the body, and the environment. Because obviously, if you have a prosthetic limb, or let's say you have a transtibular amputation, an amputation below the knee, you don't have any muscle tissue, joint tissue there for the brain to interact with anymore. but you still need to construct a prosthetic limb that allows the individual to interact with the real world. And so what you need to do is you need to actually look at able-bodied movement, look at a human that doesn't have an amputation, but then you need to understand what kind of behaviors does that lower limb need to express that still allows it to interact with the real world, but that doesn't require too much neurological control, where the nervous system is trying to micromanage all the isolated muscles and all the individual joint angles. Because that's a very noisy way to move, right? It takes energy to look after that from a neurological standpoint. So I coupled that with a lot of the research that I was obviously reading up on at that time when working with clients with persistent pain. And one of the key things, the most common things you come across is that individuals with persistent pain actually have too much neurological activity. There's too much excitability in the nervous system, where the nervous system is trying to micromanage everything. And you can see that in how they move. You see that their movement's not very fluid, it's not very effortless. It's very pre-planned, it's very slow, it's very labored, it lacks smoothness. And so what I went on from there then is I took a lot of functional neurology courses, where the actual goal is to try and drive as much challenge and stimulation to the brain as possible. You're trying to find areas of the brain that, you know, are lacking stimulation, that are under stimulated, and stimulating those to improve how the nervous system interacts with the body. But that's all well and good if you're working with somebody, you know, if with an athlete or with anybody trying to improve their movement capacity. But when you're dealing with pain, everything changes, because you have all these other kind of behaviors that occur. And one of those general behaviors from a neurological standpoint anyway is that hyperexcitability within the nervous system. So for me, it was more about, how do I actually reduce the need for the brain to interact too much with the body, to micromanage everything, and how can I allow the nervous system to offload the workload into the musculoskeletal system, so that the musculoskeletal system can actually handle distribute stress on its own without too much top-down neurological intervention, where the nervous system doesn't always have to express too much energy, right? That for me is more, even when you look into motor control, that's efficient movement, where you can move without having to micromanage everything, without the brain having to look after everything, right? It's like if you're in a business setting, you want a manager that delegates tasks across, you know, the employees, that all have different roles. You don't want a manager that micromanages every little thing that you're doing. It's the same thing with the body and the brain. You want a body that can distribute workload amongst itself. And obviously the nervous system will need to have some kind of influence, but it's not there from a micromanaging standpoint. It's not trying to look after all the joint angles, all the isolated muscles. And that's why, you know, with IKM, we don't take an approach where we're trying to find, you know, what isolated muscle is not activating properly, or is that underactive or overactive. We look at the properties of the musculoskeletal system and try and understand, well, how does that tissue behave to allow the individual to manage the forces that are acting on it from a real world standpoint. You know, when you're moving in a very dynamic environment, a changeable environment, even then you don't have the capacity to consciously micromanage all those individual muscles, because they all have to interact with other muscles and interact with the environment. So movement in a real world environment should be more, it shouldn't necessarily be more subconscious in nature, but you need to strategically understand where you want to distribute that conscious awareness. And ideally, you shouldn't be thinking about what your body is doing when you're moving in a real world environment. You should be looking at what's happening in the external environment. So your attention shouldn't be distributed internally, it should be distributed externally. But what pain does is it causes you to retreat your attention back into the body, away from the external environment and back into the internal environment of the body. And that makes your movement, you know, a little bit more labored, a little bit less coordinated in nature. So really it's just about, for us, we kind of look at this global interaction between the brain, the body, and the environment. And what we find most practitioners don't necessarily consider is how the environment impacts the body, and then how that impacts how the nervous system interacts with the body. Because we don't move in a very simple environment. It's a complex environment. It's always changing. So you can't always pre-plan your movement. So you need to look at the properties of the musculoskeletal system of the body that allow for it to interact well with the environment without too much neurological control. So it's almost like this equation where you don't want too much nervous system activity to allow the body to interact with the environment well. You want less neurological activity to allow the body to interact with the environment well. But you need to look at what properties are there. So then you're looking at biarticular muscles, you're looking at the joint configuration from distal to proximal, you're looking at distal to proximal load distribution, you're looking at, you know, how the bony segments are organized from distal to proximal. And like the body, the skeletal system, your movement apparatus as a whole is organized in such a way that you can handle stress well from distal to proximal, better than you can handle it from proximal to distal. And so all these kind of properties we've coupled together to put together kind of an assessment and treatment framework that just, I feel, you know, I use it every single day in clinic. We've taught it to many people all over the world. I think it makes the assessment and treatment process much more, much easier to understand, you know, how to restore those load sharing qualities throughout the body without trying to become too narrow focused and just treating the side of pain, you know.
Yeah.
So there's obviously lots of pieces in that to branch off of, but we started IKN based on just the integration of lots of different courses that we've taken, you know, lots of information that we've learned from mentors in the past, and that we've kind of put our own unique spin on it, I suppose you can say, to couple that with more traditional physiotherapy, traditional rehab approaches, because obviously you can't go too deep into the nervous system when you're working with a client in persistent pain, you know, because at the end of the day, they don't often care about how the nervous system works. But usually people that are very neurologically kind of driven, from at least from a practitioner standpoint, where you're all about the brain, you tend to be talking to your client about how the brain works, and they don't really care about how the brain works. They just want to get better. So you have to kind of find the balance there. And that's what we try to do with IKN, is try and find that balance between the brain and the body, but also integrating the environmental influences on the body as well.
I have to say I've taken a lot from it myself, following along with you for the last while, and I think you're onto something that's way ahead of what they're teaching at the moment. Like I'm out of university there with my master's in physio last year, and they do talk about the neuro side of things a good bit, but it's definitely not as much emphasis as there should be. And when you look at that, what the people that are coming out of college now, and think about what the general public actually know about it, it's very little. There's still that idea of let's say sitting posture, different postures that you have to hold, and how that's affecting you all the time, and how that's the mechanical side of things. I think people are probably focused on a bit too much. And I'm hearing all the time like different things about like sleep pillows, different pillows you have to buy for your neck to keep it in a certain position and all this stuff. But I think I want to dig into what you were talking about there, so people that are listening will have a better understanding of what you were getting at. As an example, when you say, looking at first, when you were saying conscious control of the body, is that like when you look at someone with back pain, very, very common feature is that they'll never bend their back. They'll always be in a very rigid position, bending down to pick something off the floor. And it is a conscious thing at the start, isn't it? But then it kind of becomes more of a subconscious pattern. Would that be similar to, on a very basic level, one of the things that you would address? Yeah.
So like when you see clients, and look, you see it almost every day in clinic, in clients that have lower back pain, that they don't want to actually create any kind of movement through the low back tissues, because when you're creating movement through the low back tissues, you need to allow for stress.
Sorry, Ryan, for some reason the speakers just seems to have gone off there on that. Is that my side or your side? Did you hit the... Can
you hear me there?
Yeah, I can.
You hear me?
It's back again now.
But in terms of, you know, watching someone bend down to touch their toes, in order for us to get an insight into how well the posterior tissues of the spine can unload, we do want to get an idea of how the client can actually interact the midline with the limbs. Because when the client's in the standing position, it's their limbs that are in contact with the world, with the external environment. So we want them to have the capacity to trust their lower limb to decelerate the midline as it goes down to touch the toes. And very, very often, if you have, because this is just one reason of many reasons, but many times where you have a client that lacks the ability to relax their spine or allow their spine to move, you're going to see that kind of rigid posture as they bend forward, or you're going to see that kind of slowness of movement where they have to stop and think before they bend forward to consciously organize that movement. That can typically occur when the individual doesn't trust the lower limb's ability to manage that stress. Because when you bend forward, obviously, you do want the midline to become a bit more relaxed, a bit more movable, a bit more adaptable. And so then if the midline's a bit more adaptable, that has to shift the workload onto something more distal. And what's distal to the midline is the lower limbs. So the lower limbs needs to be able to take on a role to decelerate the the trunk as it goes towards the floor. Because really, ultimately, what's happening there is the head's moving closer to the ground. And what's in the head is very, very important, obviously. So the nervous system wants to make sure that that's protected. But from a conscious versus subconscious standpoint, there's many ways in which the nervous system can express more protection over the body. So we talk an awful lot about the nervous system having an internal model or an internal representation of your body. And that internal representation of your body allows the nervous system to estimate the capacity of your system to manage stress and manage force as well. Because when you're moving in a very changeable environment, you need to be able to manage disturbances acting on your system first before you actually generate movement. Because gravity is always trying to pull you down to the ground, you need to be able to manage those forces acting from the top down and the bottom up before you think about trying to, move in a certain direction or generate a movement where you're acting on the world, if that makes sense. So the world always acts on you first before you act on the world, if that makes sense.
Yeah.
Okay. So if your nervous system doesn't trust the capacity of your body to handle stress, what it will typically do is it'll express more top-down protection. And one of the ways it'll do that is it'll actually freeze the range of motion potential around joint segments. So it'll usually create a co-contraction of muscles around joint segments, which will make, obviously, the structure more rigid, which limits any kind of relative motion between joints. So it limits the sharing of stress across joints and across muscles. So it actually makes it, so let's say, for example, you see someone, when they bend down to touch their toes, you see that very rigid spine where it's kind of stuck in extension. That's actually a very stable position for the nervous system. And it's a position that actually allows the nervous system to feel a little bit safer because there's not as much movement that it has to control in that scenario. So from an energy expenditure standpoint, it's more efficient because the less variability in the spine means less conscious control. Because when you have more variability in the spine, there's more muscle length changes, there's more joint angle changes, and that means that there's more feedback going to the brain then, and then that means the brain has to process all that information. And if you're somebody in pain and you're overstressed, you don't want more information to process. You want to keep the joint segments very rigid and limit any kind of variability at all. So in a sense, that rigid motion of the spine, or rigid position of the spine, makes it easier to control, but it limits your adaptability, then it limits your ability to share stress across structures. Okay, so if we had somebody, let's say, with lower back pain and they express that kind of rigidity in the spine when they bend forward to touch their toes, we need to understand, well, first and foremost, are they able to share stress across the midline segments, across the spine, across the pelvis, across the ribcage, across the head? Or is it a case where that increase in muscle activity, that increase in the rigidity around the midline is secondary to poor load sharing qualities of the lower limb? Because obviously the midline itself is not in direct contact with the environment. You don't walk around on your hips going down the street, you walk around on your feet, and your feet have to handle that stress from distal to proximal. But if your feet can handle that stress well from distal to proximal, then the proximal tissues will end up taking on that role of the distal tissues. And because the proximal tissues don't have the same architecture, they don't have the same properties as the distal tissues, then they'll typically become more rigid in nature to handle those stresses acting from distal to proximal. So sometimes when you have a proximal issue in terms of pain or in terms of movement restriction, in terms of rigidity, in terms of just a general lack of adaptability, what we do first is we understand, well, is this an actual proximal issue where we need to put more focus on restoring that dissociation, that coupling between the proximal segments? Or is it a case where we need to go distal first because what we're seeing proximally is a reflection of poor qualities distally, right? And so I've made this mistake lots of times with clients where they come in with back pain and I just want to get their limbs loading more first. And these are mistakes I made early on, in the sense that they had low back pain. I just thought, I did the assessment, we found that the limbs weren't able to handle stress well. And so I got them handling stress of the lower limbs on the first session, trying to get lots of load going through the foot up through the chain proximally. And it actually made them worse because what happens there is that if you have pain in the lower back, right, you have to understand the conscious and subconscious dynamic of pain. And pain obviously will bias more conscious behavior. because it has to get your attention. Like if pain was subconscious, it wouldn't really have any purpose at all because you wouldn't be aware of it. So pain has to be conscious in nature. So if you understand that kind of conscious versus subconscious dynamic, you can appreciate that in that moment of low back pain, if there's more conscious awareness at the spine, there's probably less conscious awareness at the foot, because you can't be consciously aware of both, especially when you're walking through a very changeable, dynamic environment. Conscious resources are very limited. They're very finite. You don't have the ability to think about every part of your body. That's why when you have pain in a certain area, it brings your conscious attention to it. So if I have somebody with an actual issue in the low back and I shift the conscious awareness into the foot too soon, that actually might put too much threat onto the system, where the nervous system doesn't feel safe anymore. I'm trying to force that awareness into the foot, and as a protective response, then the muscles around the spine are actually increasing the muscle activity. So that in those kind of scenarios, you need to know when you need to put more focus proximally first, and then take baby steps towards the foot. But sometimes you need to actually, you could potentially go into the foot faster or sooner during the rehab process. But this is all based on the client's unique past injury history, their unique movement habits. If somebody has a history of low back pain and they have had an injury in the low back and they come to see you with low back problems, you're probably not going to shove the force into the foot too soon, but you're going to try and get some movement around the spine first. But if you have somebody that comes to see you with low back pain, they have no history of injuries in the low back, but they have a history of ankle sprains, multiple knee injuries, then doing lots of work around the low back in that scenario to restore that movement is probably not going to give them the long-term change they need. You need to get that load into the distal tissues, the foot and the knee, to improve how well the nervous system can actually handle stress to those areas, to reduce the need for the proximal muscles around the back to handle stress. So it's always that kind of global kind of lens first. Do we need to go proximal? Do we need to go distal? Understanding how pain influences conscious awareness, and knowing kind of what sequence to incorporate the rehab first. Because I think for us, it's never really that, okay, there's one exercise that's best. It's about the sequence that you actually apply the load and the exercises in. That's really the kind of the main thing for us.
Yeah, and that's a really interesting way of putting it as well. The way you were discussing that proximal to distal and how it can be different for everyone depending on their injury history, especially as you kind of dug into it there with the ankle injuries and how that would bias that side of things. But looking at that and digging into it a small bit more, and pain is something that I'm very interested in, because the majority of the clients that I take on that I work with will be longer term. So it'll be like people who have injuries for a couple of years. So similar to yourself, what you were dealing with persistent pain patients. And really a lot of the time it's very difficult to get past that, or not difficult, but you have to educate them around what is pain and what's contributing to pain. And one kind of a way I would use it is that when I'm looking at them here, and if they're bending down and they're touching their toes and they're very rigid in doing that you kind of nearly have to discuss, not to break it down for them and say, look, you're like a stick there, you're like a bending over, you're like a broom bending over, yeah. But to kind of give them a better idea of changing the smallest things first. So get them kind of lightly rotating first, even turn lightly, just tucking or slight flexion to maybe start with the spine bending down towards their knees, touching their knees, coming back up again, and getting them more used to it. Because what I've found, and the reason I'm digging into this or coming into this, is that if you, as you were saying, if you go at it too fast, that nervous system does fire up into protective mode very, very quickly. And you can be set back a week then with the fact that they've gone into this protective mode of extremely high pain, very, very, very low tolerance to any movement at all. And what I'm digging at, what I'm kind of getting into there is that due to the nervous system going into a protective mode because of a higher sensitivity around the back, because of, let's say, they have this belief that they shouldn't do that. That's something that they shouldn't have done. I'm not supposed to bend my back. I'm not supposed to do that. So that conscious side of things come back in. Do you think that also plays into it as well, because of that belief of definitely shouldn't have done that movement, and I'm not supposed to bend my back, and my father had a bad back before me?
Yeah. Like, that's a good point, because when people think of, the expression of pain in a certain body part, they think, okay, well, there's obviously too much force going into that area, and it's creating sensitivity in the tissues around that area, and obviously that's creating irritation, and that's leading to a pain experience. But it's never really just a physical thing, especially when you're dealing with persistent pain.
Yeah.
And that's why we find it really helpful to use that kind of internal model approach, in the sense that, to make it simple, what we do is we separate the body into 3 global body regions. So you have the upper limb, you have the lower limb, you have the midline. Right? Your brain has an internal model or a representation of each body region. And that internal model not only stores the physical experiences of that body region, how forces have been transmitted through that area, how those bony segments move together, how the muscles interact with all the muscles and with the joints, but also past injury experiences, and not even past injury experiences, but also your thoughts connected to that body part. So let's say you have a low back pain, and you didn't really have any kind of trauma to the low back, but maybe you went for a run one day, let's say you just started the couch to 5K kind of thing, and you're a desk worker, you're sitting at your desk 8 hours, 9 hours a day, and you decide to do a couch to 5K thing, and you go for a run, and all of a sudden your back starts to hurt. Now you could look at this in many ways to say, okay, well, is there an issue in the back, or were the limbs just not capable of handling that stress when you were going for a run, and now the back is taking on that workload? That's more of a physical way of looking at it, looking at how forces are transmitted through the system. But then, in order to make sure that issue doesn't turn into a persistent issue, that's where education needs to come into play. Because if they go to see a physio and the physio says to them, okay, you've got a really bad back, you've got lots of spasm, you might have a disc herniation, you shouldn't move this way, you should move that way, giving them rules to move, then they're going to start to develop these thoughts potentially that I shouldn't move that way, or I've got a bad back. And those thoughts, that self-talk, actually becomes a component of that internal model of the midline, right? So the thoughts that you say to yourself become a component of that internal model that the brain uses to estimate the capacity of the midline to handle stress. So that's going to alter how the nervous system then interacts with the spine, because every time the spine begins to move, that's going to trigger the past experiences, and it's going to, so here's the key thing, and this is where it gets a bit complicated, because even before you move, your nervous system needs to develop an estimation as to how well that body region handles stress. So even before you move your spine, the capacity of that spine to move is dependent on the prior experiences of the movement across the spine, but not just the movement, but also the thoughts that you've had in the past about the spine. So if you've constantly been telling yourself that you have a bad back, you shouldn't move this way, you should move that way, you're probably not going to move the spine in a very fluid manner. And so those thoughts, those beliefs about the spine can contribute to a certain way of a certain behavior around the spine, right? So if those thoughts become really influential components of that internal model, and we don't actually disrupt those, they could continue to move with a very rigid spine because they don't believe it's safe, even though you actually improve how well the physical forces move through that spine with your exercise interventions. You need to help that client understand that the spine is organized in such a way that it can actually share stress. We have all those, because I like to use the actual muscular and joint properties of the body. I have a skeleton in my clinic that I use to show them, look, you see how the segments of the spine are there's a very small distance between those segments. That allows for a nice relative motion, nice segmentation of all those joints to share stress across. But if you keep those segments very, very rigid, then what those segments look like is they look like the femur, right? Since you have a very long bone, and obviously nobody wants their femur to move like a spine, right? So that's obviously not going to be a very good internal environment to allow for stress. So that gives them a picture of, how stress moves through the body. But if you're thinking about moving your spine like a femur, that's not going to allow that spine to be very adaptable. So you're changing their beliefs, not in a way that's kind of very fluffy. Do you know what I mean? Like sometimes you'll kind of get into a situation where the client almost feels like you're trying to just talk them out of pain,
Yeah.
But at least if you can use a physical model to just give them some perspective as to how the skeletal system itself allows for sharing of forces, it just helps them understand, well, geez, yeah, the way the body's organized is it's organized in such a way where my spine should allow for that sharing of stress when it moves relative to other joint segments. And so helping them understand that their spine has the capacity and that it's organized in such a way to allow for that to occur will hopefully help disrupt those negative beliefs about keeping the spine rigid. because it has evolved to allow for that sharing of load. But the key thing there is that, the self-talk, the beliefs that you have about your pain, the beliefs that you have about the capacity of your body to handle stress becomes very influential in the estimations that your brain makes about the capacity of the body to handle stress overall. So if you think negatively about your body, I almost think about like in this way, like if you talk to yourself and you say to yourself you have a bad back, or you have a bad knee, a bad hip, what's your brain going to think?
Yeah.
Because your brain's just using the information that it gathers from the environment, from your body, from your words, to develop an understanding as to how your body handles stress. Your brain lives in a dark cave, inside the skull. Like, it doesn't have any access to the outside world, so it needs information to develop those estimations, to develop that understanding. So if you're telling it that you have a bad back, a bad knee, or a bad hip, it's probably not going to feel very comfortable with you moving that area, or it's not going to feel very comfortable with that area handling stress and forces. So that those beliefs definitely need to be reshaped, at least. Like, you're not going to change a client's world in one session, where you're going to change their whole perception of how their body moves and their beliefs about, like, if they've been told by many doctors that they have the spine, if they're, let's say I see this way too much anyway, like 20-year-old, 30-year-old, and a doctor telling them they have the spine of a 70-year-old, 80-year-old, like, that's going to take a while to disrupt that type of patterning, that type of behavior. So that you have to show them how they can allow for that movement through physical movement, through a skeleton model, potentially through other educational methods as well, right? Even potentially through research.
Yeah.
So what I mean? I think people too often focus on, I need like a script in place, like, to educate my client. But in actuality, like, it occurs over a period of time, and you need to approach things from multiple angles, depending on the client's understanding as well. That influences things massively.
Yeah, that's really interesting about, you were saying there how past injury experiences are going to affect the different strategies. And I think what you were touching on there with where the thoughts become part of a midline model or midline strategy, that makes so much more sense now. And is that, do you reckon that's across the board? Do the thoughts mostly affect the midline as opposed to the upper and lower?
No, I the way we would interpret that is that we'd actually use it for the upper limb and lower limb as well. Okay. Just from a framework standpoint. It doesn't mean that this is like the brain actually houses an internal model for the midline and for the upper limb, for the lower limb. It's obviously, it's very interconnected in the brain, but from a physical therapist standpoint, or from just to make it easier from a clinical standpoint and from an explanation standpoint, it's better to look at these body regions separately, because they actually all have different roles when it comes to handling stress.
Yeah.
So the spine shouldn't behave like the arm. The spine shouldn't behave like the leg. And so each internal model will take on different, will have a different component and different content, if you like. Like, we use that filing cabinet analogy. You have a different filing cabinet with lots of different contents for the upper limb, the lower limb, and the midline. They're not always going to be the same, but it's important that they're not always the same, because if you had body parts that did all the same thing, you wouldn't be very adaptable.
Yeah.
It's like having a house, and every house, like, you look at the house from the outside and it looks beautiful. It's a mansion, it's gorgeous, but every room inside it is a bathroom. That wouldn't be a very adaptable house that actually meets your needs. You know what I mean?
Yeah.
So you need to have parts of the body that take on different roles, different behaviors, that allow for an adaptable system. But that's what, and this is the key thing, that's what makes biomechanics, or just looking at the mechanics on its own, very futile, because even your thoughts will change your biomechanics. You might say to yourself, okay, someone's pelvis is moving well into posterior tilt, so all we have to do is put them in a position where they can posterior tilt their pelvis, and then get some muscles to fire up around that area. But if they have a belief that, their spine is very rigid, and because it's rigid, it needs to be rigid because they have disc herniation and that they shouldn't move their spine, then good luck getting some a positive outcome from that exercise, unless you alter their beliefs about the organization of the spine and how it should move, and how we restore adaptability. Because there's multiple layers to that internal model. It's not just how the muscles and bones move. It's about how the nervous system interacts with those areas. And that's really the most important part of the equation for us anyway.
And when you were looking at that, like that model of of how the thoughts are going to affect it. And kind of, I wanted to dig into something there about the conscious versus subconscious. First off, we were talking there about if you go running, you have a sore back, and then you start getting all this conscious thought of like, oh, Jesus, I shouldn't have done that. I'm after damaging my back again. My father always had a bad back and I shouldn't have done that. And now they sit in the couch for the next 3 weeks because of it. And then they start to develop really serious back pain. But from a conscious versus subconscious strategy, does that mean that, or not does it mean, but do you know, let's say somebody gets a severe disc bulge, let's say L5 in it, and it's actually prudent touching off a nerve and they're getting severe symptoms on their leg. Do you reckon that's a result of previous like changes in thought patterns that made their spine more rigid? Now, I know obviously the thing is, I completely understand that like 1 in 3 people over 20 are going to have a disc bulge and all that. I'm talking about where it gets so severe that it actually bulges out far enough and starts to touch off the nerve. Do you reckon that's an aftermath of this conscious first turning into subconscious pattern, and that the body just becomes so rigid, anchors off one spot?
Yeah, like it you need to kind of look into that and understand, like, was it a traumatic injury initially, or was it a more kind of chronic issue over time?
Chronic, yeah, I suppose.
And then couple that with what an MRI shows, because look, at the end of the day, you can't improve everyone's pain experience with exercise. There are some situations that require surgical intervention to alter how the mechanics are behaving, how the mechanical structures are interacting with each other. And so I suppose, like, theoretically, you could say, yes, if somebody has had a small injury, a small strain of their back, let's say, where the back was just overloaded by doing too much too soon, and then you have a path you can go down. You could see a physio that makes you feel relaxed and says, look, it's just a little strain. We need to get movement back into that area and restore the capacity of those structures to handle stress. It's nothing major. It's just, a little hiccup in your training program. But then you go see a different physio. You could take the other path and go see a different physio that says, okay, rest for 3 weeks. You've obviously kind of caused some real trauma to the back. You might have a disc herniation. And Jesus, your hips are really, really stiff, and the rest of your spine is really, really stiff. You should never run again. That's going to alter your trajectory going forward then. And that change in your behavior then as a result of that interaction with the practitioner may then alter the mechanical forces moving through the spine, which may theoretically, change how the discs are behaving as well, and could potentially cause a chronic issue. So it could be chronic in nature, or it could be, a traumatic issue, where, you actually have a fall or a trauma through the area. Like I said, there's some situations where, and there's loads of evidence to show that, look, a disc herniation can kind of retrieve or retreat back into the between the vertebrae, right? So they can spontaneously kind of retreat back into the vertebrae where they don't maintain that disc herniation. And even like allowing the clients to understand that they can heal from that is very important. But you will have clients that that just don't have any positive outcomes from physiotherapy, and they've seen multiple people. But in terms of conscious versus subconscious kind of dynamics in that scenario, like if there is a mechanical disruption in an area, that will definitely cause more of a heightened distribution of conscious control around that area. Right, but that could be because of a mechanical disruption, or it could just be because of a lack of ability to kind of move that area, because the client is just scared stiff of moving that area. So in that scenario, then you need to make sure that you kind of load the clients in a manner that meets their unique needs and their limitations. Because look, if somebody has a severe disc herniation, I'm probably not going to just dump a lot of stress into the lower limbs, because when we're putting stress into the lower limbs, you're doing that in a way that where you also want the spine to express the ability to be adaptable. You don't want to be loading the lower limbs and have the spine stiff and rigid, because that defeats the purpose of trying to get the limbs to handle stress while on their own in the first place. So if you're putting too much load into the lower limbs and the client is still continuing to place all their conscious awareness in the low back because they're trying to protect a mechanical disruption in the low back, then they're probably not going to feel much better after that exercise. So in that scenario, you do need to, like you said there before, you might need to get some gentle movement into the spine first. Allow the nervous system to feel comfortable with a little bit of movement between the pelvis and the rib cage, across the spinal tissues. And then once you maybe develop a little bit of safety with that, then you can slowly shift that workload, or even challenge the spine a bit more, and then slowly shift that workload distally. So it's not only about kind of changing the forces through the spine and through the lower limb in that scenario, but it's also trying to alter where the client distributes that conscious control. Because like from an endpoint goal standpoint, we don't want the client walking down the street consciously thinking about how their lower back is moving. Yeah. You know, we want them kind of thinking about what's going on in the external environment, and then the body will interact with the environment to handle those environmental stressors, acting from distal to proximal, from the foot proximal, from the hand proximal. So in that sense, you're looking at mechanics, but you're also looking at neural dynamics as well. Okay, because and this is where, look, it gets really complex in a way when you're first trying to understand it, because you do have to look at things through different lenses. So you can look at the biomechanics. If someone has really rigid spine, let's say they have a hyperlordosis at the spine, let's say their pelvis is kind of biased in an anterior pelvic tilt, the rib cage is really extended, they have a really kind of stiff and rigid low back. In that scenario, you need to understand, well, look, is that a strategy the nervous system is using because it doesn't actually want to handle stress through the low back, and so that limits the amount of variability in the low back, that rigid co-contraction of the spine. Because when you move the spine to extension, you move into more of a close pack position. In more of a close pack position, there's less relative movement, there's less dissociation between those joint segments. So it's safer for the brain because there's not a lot of variability there. Because variability creates noise, and it creates the need for the brain to handle lots of stress over a broader bandwidth, if you like. But like I said at the beginning there, or is it a case where that lower back is just expressing a stiffening strategy because the limbs can handle stress well, right? Okay. But that you can look at it from that perspective as, is it a physical mechanical issue where we need to get that pelvis moving better, or is it a case where the nervous system doesn't trust the properties of the lower limb, and you're seeing that expression proximally, secondary to the lower limb? And that's where you need to understand the nervous system and the internal model. Because if you don't understand the nervous system and how it needs a robust internal model before you move, then all the work around the low back with fancy kind of pelvic movement exercises and rib cage movement might actually not change the issue, because that's not what the nervous system is threatened by. It's not threatened by the lack of movement of the spine. It's the lack of load capacity in the limb.
Yeah. Okay.
Do you know what I mean? So that's just one way of looking at it. But when people talk about biomechanics, it's like, your pelvis can't move that way. Let's get it to move that way, and they think it's going to correct the issue, but it doesn't appreciate the neurological interaction with different body regions, and how different body regions need to take on different roles to allow for a nice distribution of workload. So it's like we call it background protection, just as a way to understand it. The nervous system needs a robust internal model of the body before it moves. That gives you the ability to trust the capacity of the musculoskeletal system to handle stress well. If you don't have good background protection, which that provides, then you're going to express more conscious protection methods through stiffening strategies, through lots of co-contraction, increased muscle activity potentially, and potentially an uncomfortable sensation like pain to stop you from moving. Right?
Yeah. Excellent. Well, perfectly articulated. What I would say, kind of my next question is, I suppose, moving on from there, or looking at that in a bit more detail, why would the nervous system stop trusting its distal strategies, or stop trusting the limb? Is that because of injury? Or is it because what's playing into that?
Yeah, so it's really helpful to think of the internal model here again, because let's say, for example, when I talked to you before about the different skeletal features of the limb versus the midline, you look at the foot, right? And you look at the midfoot in particular, you have a joint organization that's where the joint segments are actually very close to each other. There's a very small distance between those joint segments through the foot, right? And then as you move proximally into the tibia, from the ankle to the knee, there's a very, very big distance. And then from the knee to the hip, there's a very big distance compared to the foot and compared to the spine. In the limb, you have long bones to the femur, the tibia, and the fibula. In the spine, you don't have those long bones. So all these mechanical properties are actually components of the internal model as well. So your nervous system knows that it has that content within the internal model that helps it understand that you have these properties in the limb, right? And in order to maintain the robustness of the internal model, you need to allow for those tissues to handle stress in the way that they've evolved to handle stress. Okay, so with that being said, because you have those long bones in the limb, obviously the bones themselves can't allow for that sharing of stress. So you need muscles, certain muscle behavior to allow for that stress. And that's why you have the biarticular muscles of the lower limb. You have the hamstrings, you have the rec fem, you have the gastroc, right? And then you also have more tendinous tissue around the foot and the ankle through the Achilles. But then as you move proximally around the spine, you have less tendinous tissue. So all those properties, the tendinous tissue, the biarticular muscles, the longer bones, the smaller joint segments at the foot, and then the larger distances between joint segments in the leg itself, between the femur and the tibia, and then the spinal segmentation as well. All those properties are components of that internal model. So when you lose the ability to exploit those and take advantage of those, that's when you may potentially see excessive conscious protection through increased muscle activity, through potentially pain. And this is what I was referring to initially when I was talking about the development of a prosthetic limb. The prosthetists, when they looked at able body movements, they wanted to try and identify, what are the properties of the muscles and joints that allow for the ability to manage stress well without too much brain control, if you want to say it that way, right? Without too much neurological intervention. And the organization of the muscles around the limb was really, really key. The differentiation between biarticular muscles and monoarticular muscles, because biarticular muscles, they obviously extend a much broader length, but that allows them to share stress over broader lengths, over larger surface areas, versus monoarticular muscles, they obviously don't have that same type of behavior. And we think we don't necessarily, at least we don't feel people appreciate how these different muscular dynamics influence how load is being transmitted through the limb. Because you're not going to, for example, you're not going to load the hamstring like you would load the glute, for example, right? Because even when you look deeper into the fiber organization of the glute, you've got longer fibers of the glute. Let's look at the glute between the difference between the glute and the gastric, for example. You have a glute with long fibers. You don't have a glute with a lot of tendinous tissue. But then when you look at the gastroc, you have a fiber orientation where they inserted an angle into the central tendon. So those fibers don't move over a very large range like the glute. Like you really have to kind of stretch your hip over a broad range to get a stretch in the glutes, versus the calves, you don't really have to do that. And that's why in the calves, it's really the muscles themselves that should act isometrically because of that fiber organization, which allows a tendon then to take on the role of handling stress. So these are all properties that we feel the limb needs to be able to express and handle stress well through. So the biarticular tissue should be able to handle load isometrically, to distribute that load well across it. The glute should be able to lengthen and shorten more because of its fiber organization. And all those properties and strategies allow for a much more robust internal model where the brain doesn't feel like it needs to protect the limb consciously as much. Right, so we're developing that background protection. So that if you're someone who sits all day, 8-9 hours, are you actually giving your nervous system that understanding that those properties can handle stress throughout the limb? You're probably not. So then when you go for a run, your nervous system might not be able to trust the lower limb to handle those stress at higher speeds. And so now all of a sudden your nervous system is expressing more top-down protection, more consciously driven protective mechanisms through the increase in pain, potentially through the increase in muscle activity, right? Or on the other end of the spectrum, you could have just prior injuries in the foot and the ankle. You could have a history of ankle injuries. You could have a history of knee surgeries, and that disrupts the internal model of the brain, right? And so then it's creating that more conscious protection as a result. So there's two ways you kind of think of it. You think of it from an internal model standpoint. Is the brain able to exploit? That's one word that prosthetists will use all the time. Can the brain exploit the properties of the limb? And this is something that everyone should be able to express, no matter what injury you have. we all have very similar limb organizations. We all have hamstrings. We all have quads. We all have a femur. We all have a tibia. Most of us anyway, unless you've had an amputation, which was where a lot of this information has come from prosthetic limb research. That helps you manage stress well. Those are the skeletal and muscular properties that help you manage stress well, but they also help the brain trust the lower limb. But on the other end of the spectrum, you could have a history of injuries, like I said, in the ankle, the knee, the hip, that disrupt that internal model from that perspective. And that just creates, essentially what it does is it creates a lack of trust, a lack of trust in the capacity of those tissues to handle stress, so the brain doesn't need to express too much conscious protection. But the key thing that I wanted to make sense of there, which is tough to do in a very succinct way, is that the way in which you actually develop that trust is different, because you can't just train the glute like you would train the quad. You can't train the glute like you would train the calf. You can't load the foot like you would load the knee or the hip, because they all have different roles and behaviors based on their organization, their architectural organization. So that's what we base an awful lot of our rehab interventions on. On one end of the spectrum, we're trying to exploit these properties throughout the limb to make sure that the brain doesn't feel the need to express too much conscious protection, potentially in the form of pain or increased muscle activity or rigidity. But we're also trying to appreciate and integrate the unique limitations that the client has, right? So sometimes you might have a client with knee pain. Let's say you have two clients with knee pain, and they obviously both clients have very similar organizations of the muscles and joints around the knee and around the foot and ankle and the hip, but client one has a limitation in external rotation of the tibia. Client two has a limitation in internal rotation of the tibia. So those are two kind of local limitations that you need to consider when you're actually loading them. But they still have a hamstring, they still have a glute, they still have a calf, they still have an Achilles tendon. So those are the universal features that are unchangeable, you can say. But the local limitations are the things that change. So you're trying to pair changeable properties with unchangeable properties when you load the system. Okay, because I want to load the hamstring isometrically, but I might also want to incorporate some strategy that facilitates more external rotation of the tibia in the client that's limited in external rotation of the tibia. In the client two with more limited internal rotation, I might want to load the hamstring in the same way but facilitate more internal rotation of the tibia. So I'm ticking both those boxes. I'm loading the system, I'm loading the tissues in a way that they've evolved to be loaded, but I'm also appreciating the local limitations that the client has as well.
Yeah, okay. Lot to unpack
there. Sorry.
No, that's exactly the way. You keep it going like that, because once you get going, you really dig into it, which is excellent. You really are able to kind of articulate it. Anything I ask, and it's funny because I'm going to stop you and ask you another question, but you've been answered then, so it's perfect. You just work away. Keep doing that. So what I was gonna dig into there first is that we were talking about the different strategies, how the body's going to change them, and that. Do you feel then, looking at that, like does the traumatic nature of an injury, do you reckon that affects how much the body emphasizes that? Because let's say someone was in a car accident, and that's going to change. Obviously, it's such an emotional experience, as opposed to somebody who was and let's say they break their leg or something like that, or hurt their knee in a car accident. Now, their experience is way different to somebody who's, let's say, running down and then their knee, they step in a hole and it just twists, and they get up and they go to hospital and they get it checked and they're okay. They get an ACL surgery. Do you reckon that traumatic side of things also has a huge effect on how the body registers that injury and changes its distal strategies around it? Does that make sense?
Yeah, definitely. No, it does. And you brought up a really good point there, because, when you have a traumatic injury, I think people tend to think that the brain only registers what happens in the muscles and joints, but it doesn't. It registers what happens from your visual system, what you smell, what you hear, what you taste. Like we all have that ability to, you smell something and it brings you back to a memory, 10 years, 20 years, 30 years ago. But it doesn't actually just bring you back to the memory. It actually brings you back to the feelings and the sensations that you felt at that point in time, which is really an incredible thing, isn't it? When you think about it, like you can smell something and it just brings you back to a memory, but not just a memory, but also to the sensations that you felt at that point in time. And that's really the internal model in action, right? Because when you smell that same smell, that that causes let's think of it this way, that causes your brain to go back into the filing cabinet and say, okay, where have I smelt this before? And so pulls out that memory where you smelt that before, and then it just relives the sensations that you felt at that point in time. So that is really the essence of an internal model, because the internal model doesn't just store physical properties, it stores all the sensations from that point in time.
Yeah.
Right. Which is really, I find that really fascinating. That's why, we do not only look at the mechanics, we look at other sensory systems as well. So the visual system, the vestibular system, and so on and so forth. But let's say, for example, someone injured themselves in a car accident and they have a whiplash injury, and they go for therapy. They're getting some mobilization in the neck, they're getting some strengthening exercises around the neck, they're getting very traditional stuff done. But they go back out into the car, and because they're in a car, that visual understanding of their surroundings triggers that internal model. They say, damn, last time I was in the car, I had that awful injury. So that's almost reliving those kind of threatening experiences. So sometimes you will have to kind of allow the client to develop, certain relaxation strategies to express outside the clinic, when they're in a car. Because a lot of clients will feel very, very threatened and very, they just won't feel very safe in a car again, obviously, if you've had a car accident. And that's gonna be reflected in the muscles and joints. You're probably not going to be very loose and relaxed and mobile when you're in a car just after being in a car accident. But that can be continued to be expressed down the road if you don't actually teach the client, self-treatment exercises, self-relaxation exercises to do in a car. And that's just an example. I'm not saying that, that has to be done with every single client in that situation, but I think it really kind of, it strengthens this understanding that you need to give the clients things that they can do at home outside the clinical setting, because a lot of times, these injuries, these experiences happen outside of a clinical setting. You don't get injured on a treatment table, so you do need to give the client things at home. Hopefully, anyway, yeah, that's the first thing. Do no harm at first, right?
Yeah.
But if you don't give the client the tools to reproduce those changes, or to continue to express the movement strategies that you're doing in clinic, you're probably not going to get much long-term change, if we're being honest, right? Because you're not really allowing the client to express that same behavior in different environments, right? So you're going to move differently in a clinical setting than you're going to move in your car just after a car accident. You might feel more rigid, more stiff. So that's just an example of why you need to give somebody things to do outside the clinic. And that's why you shouldn't really, that's why I feel as though all these complicated manual treatment strategies, these fancy looking passive treatment strategies where you have to get the client into the perfect position to either do manipulation, or all these overly complex rehab mobility strategies where the client has to be in the correct position to get things done, I don't think they're helpful in the long run, because it makes the client feel as though, geez, I can't do this at home on my own. I'm not going to be able to express the same kind of movement at home. And therefore I might not be able to, I'm going to become more dependent on the therapist for one, but I'm also not going to be able to maintain those changes outside the clinical setting. So there's lots of layers to that. But I think the most important point being there is that any kind of injury or threatening experience is registered by more than one sense, and each of those senses become, this is the idea of neurotags, based on the Laura Mosley's research and David Butler's research, is that pain will become tagged to certain sensory experiences, right? So you can have, think of that, just that visual experience of being in a car, that can potentially bring up that same sensation of discomfort and pain that you felt at the original, during the original accident. Or put another way, let's say you're deadlifting in the gym, and you hurt your back in a gym environment. You go to a therapist, you do all the exercises, you get your rehab done, you actually feel good doing stuff in the gym, you feel good doing stuff in the clinic, but you go back into the same gym environment and all of a sudden you feel quite rigid going back into your deadlifts. Nothing's wrong physically, but it's just the visual scene of a gym environment that will become that, because it's tagged to your pain experience, that will make the brain potentially feel a bit more threatened, because the brain will say, shit, last time I was here, we got injured. And so I'm going to protect you a little bit more in that scenario, even though everything mechanically might be sound. but it's just the visual experience and how that visual scene is tagged with the pain experience originally. It relives the sensations, just like you smell something, it brings you back to your memory. You don't just relive the memory, you relive the sensations and the feelings, whether it's good or bad. Right? That's why humans are so complicated, because we have the ability to think back to things that annoyed us, and we feel anger, and we still feel that same kind of sense of just annoyance about something that could have happened 10, 20 years ago.
Yeah, exactly.
It's funny, but it's a interesting feature that humans possess. But I think it's also one that definitely has a negative impact on our experience, of life, because we have that ability to think back to things that have previously annoyed us.
Negative and positive. There is definitely other things as well, in terms of, like, as you said, if you get a smell, it brings you back to a great time in your life as well. So I suppose there is both sides, but in life, like, and looking at like, I suppose some of even the sleep research, we are more biased to I suppose have a negative remembering bias. Like we're more biased towards saving negative memories as opposed to positive, and you can see the survival side to that. But so that I wanted to get that question across, or see if you see what your opinion was on it, because I noticed, like, a lot of clients that I would have worked with who had an injury that involved, like, a lot of embarrassment. Let's say if they were at a nightclub and they fell down and they hurt their hip or hurt their back, they were the ones that really stuck around a lot longer, and they were less likely to even start, like, moving themselves properly again, or even start dancing, like very afraid to start dancing again. But it wasn't because it was, like, obviously it was because the second they started dancing, they relived that memory of, all right, I fell over and I hurt myself, and all these people saw that happen to me. So I found, like, just getting them doing it at their own house, just kind of letting them get moving again, put on your favorite song and start relaxing down, it was really helpful. But I think it ties into that internal model, does it?
Definitely. And, like, where I actually became aware of this initially was from a guy called Joaquin Farias. He's a Canadian therapist, and he actually works with clients with dystonia. And his stuff is fascinating. It wouldn't be for everyone, and it's not that we do this in clinic, but I think, the way he goes about treating people is very, very interesting, because he won't actually do any physical treatment on you until you actually reconnect in some way socially, right? So if let's say you were a dancer and you have an ankle injury, or you have some other kind of neurological issue, he's treating clients with dystonia, which is more of a neurological condition. But he wants you to reconnect socially, just to give your body a little bit more of a positive experience, because he knows that if he's treating you when you're very negative, and when you know that, geez, I can't dance anymore, that's not creating an internal environment that allows for positive change. So even if it's just visualizing yourself dancing again, he has you just sit there and visualize yourself dancing, reconnecting socially from a just a visualization standpoint, or even just go back to the dance studio where you were and just watch people dancing, reconnect socially. Then once you do that for a while, then he will begin treating you. But I think that's just a fascinating thing, because it emphasizes the importance of looking at other non-physical factors in your capacity to develop positive change from a rehabilitation standpoint. If you're really, really down in the dumps because you can't dance anymore, and you're very, very negative, and it's going to be very, very difficult to kickstart some kind of change in a positive direction in that scenario, right? Because, like we said before, there's just so many non-physical factors that contribute to a pain experience. But that's why we don't necessarily try to incorporate that to a great degree, but from our standpoint, what it tells us is that there needs to be a large emphasis on allowing clients to express the strategies that we want them to express in a clinical setting, in a non-clinical setting, at home, in different environments. So we don't want to make treatments too complicated in nature so that they feel dependent on us. But what we also want to do is we want to try and access and have an influence on as many layers of the system as possible. That's why we're looking at the general behaviors of the nervous system with different parts of the body. How the limb, the upper limb, lower limb, midline all behave differently. If we can appreciate other layers, instead of just saying, okay, your glutes turned off, let me activate the glute, instead of just doing simple stuff like that, and it's overly simplified, because obviously, just by getting someone to contract their glute, it might change how load is being transmitted through the limb, but is it really restoring a much more robust internal model without also addressing the rest of the limb and how that glute interacts with the rest of the lower limb and the foot and even with the midline. So by looking at it from that perspective, we feel as though we're having a greater influence on more layers. We're teaching the system to develop a better understanding of how well the system can handle stress and protect itself, so that we don't need that excessive top-down protection through pain potentially, right? But I really kind of I admire the work of Joaquin Farias in that, and not a lot of people know about him, but his work is really, really fascinating, and just how he works with clients. He does a lot of coordinated work. He does a lot of kind of visualization work as well. But I think while that's not for everyone, obviously in a physio setting, like you're not going to have a client lie on your treatment table and visualize themselves dancing again, when you're working on their ankle. But it's just it's what, the underlying kind of feature that you're trying to allow the client to express. You're trying to allow the system to just develop a little bit more of a changeable internal environment. If you can be a little bit more positive in how you can perceive the world, then it's going to have a greater influence on how much resources you can put forth when you're trying to express positive change. It's just that kind of that point, I think, is so undervalued, from a physio session, from a traditional physiotherapy standpoint, because look, we just think of muscles and joints, but you're so much more than just muscles and joints.
I must actually look into him. I haven't heard of that before, but it does, like, that's rehab that's based in what you could say is like the client goals in terms of like their function, or what their goal is to get back dancing. So you can be doing all the single leg balance stuff in the world, but until they actually have change their mindset in terms of, I can actually get back and do this, and I can start to do things I love again. And that's really what it is. I think people do get mixed up, and when you're in college and you're coming out of it, there is probably a bit more of a push on the mechanical side of things, because you have to learn all the anatomy, you have to learn all your treatment techniques, and you have to do that. So you're trying to apply them in it. And I think sometimes you do get lost in the fact that actually this is just a person I'm dealing with here, and they want to get back to doing something that they love doing. They don't give one shit about, like, if you're fucking teaching them how to stand on one leg and you're teaching them how to maybe do single leg hops and stuff like that. Does that transfer to, let's say, them getting back running? Does it transfer to them getting back dancing? And if it doesn't, I find it, like, you have to do them at times, obviously you have to do it to build up tolerance in the tissues and that, but there needs to be that end goal of getting back to what the function or what the activity they were at. So I think that's a great idea. I'm definitely going to look into him, because I love that type of side of things. Joaquin Farias, as you said.
Joaquin Farias.
Oh, Farias, okay.
Farias, yeah. He's based out of, I think he's based in Toronto, Canada. I did one of his workshops in New York City when I was there. But geez, after college, I did so many different workshops. Went to so many different courses, and each course says a different thing. And while they've all helped, to help us, put our own unique twist on how we approach things with IKN. There's never one way of approaching, assessment or treatment of the body. I think the best approaches are the approaches that, integrate the unique limitations, the unique experiences of the client, because every client's going to be different. They're all going to have different limitations, or always going to have different experiences. But then you have to also integrate the universal features of the musculoskeletal system and how the brain interacts with the musculoskeletal system, which we spent a good bit of time talking about in terms of how the midline is organized, the lower limb and the upper limb is organized. When you meet those two together, I think you have a really solid, robust assessment and treatment framework, because you're looking at both. Like we would look at that as, like, when someone comes into a clinical session for a consultation, the client will always have consciously driven goals, right, that they want to get back to. But the nervous system's goals don't always match the consciously driven goals of the client, because the nervous system's goals are always about protection. Your nervous system wants to keep you safe. Your nervous system doesn't care if you can walk up and down the stairs or if you can go for a 5K jog. It just wants to develop that trust with the body again to handle stress. But we know now that how your thoughts have an influence, your ability to connect socially has an influence. The certain properties of your muscles and joints have an influence. So you have to match or marry those two kind of organization features together, the unique limitations of the client, and then the actual nervous system goals, how the nervous system interacts with the anatomy to allow it to handle stress well in the environment. So we look at consciously driven goals and the nervous system goals, and it's just bringing them together.
Matching up, yeah. And Yeah, that's a good way of putting it. And what I want to actually dig into now is that filing cabinet analogy that you talk about. Now, we have touched on it all throughout this podcast,
Yeah.
but I think if you dug into a small bit of that, because I want to just talk a small bit after that about actual treatment planning, looking at how the visual system is incorporated, looking at how the respiratory system is incorporated. But I think if you give a better idea of that, not that you've given a perfect example of it the whole way through, but just for people who are picking up on bits of it and want to kind of put it together. So what is the filing cabinet analogy?
So yeah, the filing cabinet analogy is the analogy that we use to reflect this internal model or representation that the brain has of the body. Because it's extremely complex in nature, it's very, very difficult to truly appreciate, how this internal representation allows for certain kind of movement strategies. So we have to simplify it. You have to simplify everything from a neurological standpoint to actually make it usable. If you don't simplify it, it's very, very difficult to incorporate clinically. So we organize this internal model understanding through a filing cabinet analogy to say that the nervous system has a filing cabinet of all the physical and non-physical experiences for each body region. So it has a filing cabinet of non-physical and physical experiences of the midline, for the upper limb and the lower limb. And the content of each filing cabinet is different because, like we said before, the midline will behave differently than the lower limb when it comes to managing forces and handling stresses, just like the midline will behave differently to the upper limb. So the content of this filing cabinet will be different across you have 3 filing cabinets. But the filing cabinets essentially allow for a very flexible instruction manual, if you like, for the brain to predict the capacity of the body to handle stress before it moves. So if, for example, we use the lower limb as an example, let's say the filing cabinet of your right lower limb, let's say you injured your ankle, 20 years ago, you sprained it again 2 years later, you broke it again 5 years later, you strained your hamstring on that side, you had a surgery on the meniscus on that side as well. Think about how the filing cabinet of that right limb is different from the left limb. And do you think that the content of that filing cabinet is going to influence how the brain interacts with that lower limb, the right side versus the left side? Of course it is. It might be a case where you may potentially have less range of motion on that right limb versus the left limb. Maybe a case where you have maybe a little bit more muscle activity around the lower back on that right side because the lower limb doesn't potentially have that adaptability to handle stress well from distal to proximal. And so now the midline is having to take on more workload because the lower limb can handle stress. So it's just a way to appreciate how past experiences become a component of those filing cabinets, and they influence how the nervous system develops an estimation of how that region can handle stress, because that will influence the biomechanics, right? Because if let's say you have a client that comes to see you for a consultation, and they have let's say they have hip pain, and you're assessing their hip, and you see, geez, you have very limited internal rotation of the hip there, and lots of external rotation, but then you don't appreciate. Let's say you use that information to say, okay, let's drive you more into internal rotation. Let's just do some P&F stuff. Let's push you into internal rotation. But if we don't consider, how other components in that filing cabinet have led to a potential change in the motion at that hip, we might not be able to have long-term outcomes. So if that client has a current experience of, pain around the hip or limitation in the hip, but they also have that history of injury in the ankle, history of surgery in the knee, and we don't even consider that during the subjective assessment, and we don't consider that during the rehab integration as well, we might not be able to restore the movement adaptability of that hip, but also throughout the lower limb. So it just brings to the surface the importance of looking at the entire body region, how past injuries, how other experiences influence the content of that filing cabinet, because that will serve as a flexible instruction manual for the brain. If it's a very messy instruction manual where you've had lots of problems in the past, the nervous system might not trust that limb to handle stress. So it's going to change how it interacts with it. So it's a very, very general analogy, but I think it kind of brings up a lot of interesting points and important points to guide how you might incorporate your treatment.
Yeah, and it does, like because of the fact that you were taking out, or the way you were talking about it, like past injuries, and that when I was researching it, you're looking at even like self-talk, movement, expression, movement context, and all that. Because of all that, is that because that's taken into it, now I kind of want to dive into like the treatment side of things. And the treatment side of things, I think, is the most interesting. I won't hold you too much longer, so don't worry too much about it. But what I want to look into is, first, obviously, when we're looking at changing the nervous system, it can't always just come to, right, I need you doing squats over here, I need you doing lunges over here. You need to look at the other things outside of that are going to make it more functional. And as you said, that's going to apply to a real life situation. So one thing I heard you talking about a good bit was nasal breathing, being able to breathe through your nose when you are doing an exercise. And I can see, from my perspective, before I even jump into that, I can see why you would do that, in terms of, like, first, obviously, you've got the gas exchange and that side of things, but even the ability to nasal breathe puts you into a more relaxed state. Generally, you're looking at more of a parasympathetic state. So would that be one reason why you're looking at nasal breathing? Is there other reasons why you're looking at that when you're completing exercises? When do you apply it?
Yes, for me, like, I try to explain it really in really simplified terms to the client, in the sense that nasal breathing strategy is a really low intensity breathing strategy, right? So if I'm having you do a very, low level isometric kind of hold, and you're holding your breath, you're doing that, then that breathing strategy doesn't match the intensity of the isometric. So there's a mismatch there. So I want you to try and use the lowest intensity breathing strategy as possible, while you're actually doing some kind of isometric hold, or it could be a squat, it could be a dynamic motion. But if you're using a very high intensity breathing strategy while you're doing a low intensity exercise, then that's not really allowing the nervous system to develop trust in the ability of the body to handle stress well while you're walking in the street, for example. If you're using, because when you're breathing, you're hyperventilating, or even if you're holding your breath, you're not reestablishing that trust in the system's ability to handle stress, because you're holding everything tight, or you're using a very high threshold breathing strategy, using up a lot of oxygen, using a very high energy strategy to do something that should be very, very low energy. And that's the key thing to understand, is that it's never about the load that you give to the body with an exercise, but it's about the strategy that you're teaching the system to use to manage that load. So I want the client to use the least amount of energy possible when they're handling stress, because that makes them more efficient. Right? If I'm not cueing them to use a low intensity breathing strategy when I'm doing certain exercises, they're expressing a lot of energy to do something that shouldn't be like that, and that's going to influence how their system is expressing adaptability in the real world. But that's not to say that nasal breathing is bad or is only good for all exercises. You have to match it to the intensity of the task. Like if I'm sprinting, for example, you're not going to be able to maintain a nasal breathing strategy. So the breathing strategy in that scenario would obviously have to be more mouth breathing in nature, and more kind of a rapid breathing strategy, more anaerobic, the respiratory pattern in nature, to match the intensity of the task. But it's all about matching the task with the breathing strategy, right?
Yeah, that's it. Yeah, because that, like, what I do as well in like looking at when I am working with clients, it's definitely that side of things. Is it, if you're going through this, obviously now there's, as you were saying, if you're sprinting, you can't be changing breathing patterns, like telling them to nasal breathe. But I do love that idea of just becoming aware of it first and see how it does change. And if you can become aware of it first and then look at maybe what your body wants to do. So certain positions, I always use the analogy of someone who's dislocated their shoulder. Once they go back into any position, overhead position, anything like that, they'll always get into this breathing pattern that you can just hear it straight away, a quick change in it. And addressing that, if you don't address that pattern, you can never, as you said yourself, you can never build safety in the system. You can never really, the system will never feel safe in going into that position. So I think that nasal breathing strategy is an excellent one, and one that I will apply definitely more with clients. And one that I've heard you also talking about is CO2 tolerance. And this is one that I love. I apply it all the time just to manage stress better, or to manage your ability to manage stress a lot better. Why do you use CO2 tolerance testing or CO2 tolerance training when you are in a rehab setting?
The thing is, like with nasal breathing, that is a way to develop that CO2 tolerance.
Yeah.
Right. Because when carbon dioxide builds up in the system, a lot of the times, again, you'll see a client shift into a very kind of high threshold breathing strategy because they become very stressed when there's a lot of carbon dioxide in the system. But what you also see is that when when an individual lacks the ability to become tolerant to CO2, you'll actually see the sensitivity of the nerves become heightened, right? So the proprioceptive system may become a little bit more sensitive when a client is intolerant to carbon dioxide. And so, for example, it's like, yeah, someone puts pressure on a muscle. When you're palpating the muscle and you put a little bit of pressure, you'll have some clients that can tolerate it very, very well. Some clients that jump off the table at the minute you put a little bit of pressure on it. So in those situations where the client's very sensitive to load, very, very often their system is in a state of stress, and the increased intolerance to carbon dioxide may have an influence on that, because it's going to heighten the sensitivity of the nerve fibers. So it's going to make your system feel like you're getting hit when you're actually just being gently pressed. Obviously that's not a very clear analogy, but it's one of the main reasons why we'll use nasal breathing to try and delay that shift into a mouth breathing strategy, because then you're just blowing off lots of carbon dioxide. That's why they have you kind of shift into breathing into a brown paper bag, because you can actually develop that increased tolerance to carbon dioxide, which allows you to relax and allows for the system to become a little bit more desensitized. So it's just one respiratory strategy that we can use to reduce stress, just like any other strategy that we'll use, right? Because it's not really, because any kind of rehab intervention is delivering stress to the system. When you put load through a muscle or a joint, you're putting stress into the muscle and joint. But it's not just about putting stress into it, it's teaching the system how to handle that stress, right? So when you do carbon dioxide tolerance training and you have the client either do kind of breath holding strategies or really reduce the rate of their breathing or use nasal breathing when they're increasing the intensity of the movement, you're stressing them out even more, but you're teaching them how to use strategies to manage that stress.
Yeah.
Right. And so it's really a way to desensitize the system and teach the system to use more efficient strategies to manage stress, rather than just thinking to stress the system with exercise.
Yeah.
Right. And not really worrying about the breathing strategy someone's using. Because I wouldn't really do, a huge amount of carbon dioxide tolerance training in isolation, but I'd always pair it with a loading strategy of the body. It could be an isometric loading strategy. I'd have them do different kind of breath holds. I'll use the kind of the box breathing strategy an awful lot, where they breathe for 4 seconds, pause for 4 seconds, exhale for 4 seconds, pause for 4 seconds before they inhale again. But then I'll manipulate the amount of time they hold the last pause for.
Okay.
Right. Yeah. So I'll maybe kind of inhale for 4, exhale for 4, then pause for maybe 5 or 6 seconds, and then inhale again as they're doing isometric hold, and then increase that up to a point where they can pause for 10 seconds. Then I'll manipulate the length of the exhale. The longer you're going to exhale and the slower you exhale, the more that carbon dioxide is going to build up in the body. So if you're intolerant to carbon dioxide, you're going to want to take a breath in faster than someone who is more tolerant to carbon dioxide. So if somebody who's really breathing really, really fast, has very shallow breaths, one of the best things you can do is just teach them to slow their breathing down and lengthen their exhale. Yeah. So sometimes lengthening the exhale is actually too difficult for clients. So what I find the best thing to do is actually pause for a bit longer after a normal exhale, and then inhale again. Because the exhale itself requires a little bit more coordination, but just pausing is a little bit easier for the client to do. So you could inhale for 3, exhale for 3, but then pause at the end for a couple of seconds. So I would always manipulate the pause before I manipulate the length of the exhale.
Okay.
Especially in clients that just have difficulty, because some of the clients, you ask them to take a gentle breath in, and then you have them really slow down the exhale, and they exhale for like 2 seconds, and they're just unable to do it.
Yeah.
It's very, very challenging for them to do that. So manipulating the pause at the end of the exhale is I find is just an easier way to build up that tolerance to carbon dioxide.
Yeah, and I can see you're addressing on both levels, in terms of like that their body is actually starting to relearn how to go through these positions without going into without having an overactive stress response. But at the same time, you are kind of toggling with that how would you say, sympathetic parasympathetic tone as well, because you're kind of keeping it with the extended exhale, with the pause, you're keeping it into more of a parasympathetic tone, which I guess would register into more of a relaxed state, or register as more of a relaxation response to it.
Yeah, generally you're just trying to stress the system as much as you can, as much as the system can tolerate, but try and teach them to delay an excessive stress sympathetic strategy to manage that stress. So I'm trying to teach them how to keep a very low intensity strategy to manage stress while I stress the system as much as possible.
Yeah.
If that makes sense. If I'm stressing them as much as possible and they're using a really, really high threshold intensity strategy to manage that stress, then I'm not really retraining the system to be more efficient at all. I'm trying to delay the stress response. Usually people that are in pain, they're very, very, they're almost kind of hanging right on the edge. They're very easily sensitized. They're very easily stressed. The system becomes very, very quick to express a pain experience. It's very overprotective, right? So I want to reduce that overprotectiveness, and then trying to alter the breathing strategies is a way to alter that overprotection, if you like.
Okay, excellent. And last question now of what I'll put you under now. Keep it as brief for as long as you like. But I wanted to look at, because it was something that I wanted to dig into a bit, was how do you incorporate, let's say, your visual system, your vestibular system? I know they're obviously two different things, but they do work together, obviously. But in a rehab context, when do you incorporate it and how do you do it?
Yeah, so the key thing to understand there is that, clients that come into me with pain, I'm never going to the visual system and the vestibular system first.
Yeah.
Right. You're kind of working from the bottom up first, because obviously the client doesn't really understand. Well, they might understand, but generally they don't understand how the visual and vestibular system influence the body. But that being said, based on the injury history, if a client has had a history of concussions, multiple concussions, and they come to see you with the current experience of neck pain, then maybe you might look at the visual system, vestibular system earlier on. Okay. But the main thing about
the sound is just clicked off again there, and fair. Oh yeah, it's back. It's back again.
Back. Sorry about that. But when it comes to the visual and vestibular system, they will allow for your system to modulate the amount of tone that you express, particularly throughout your midline. Right. So when it comes to the vestibular system, for example, the vestibular system will use head motion to understand where your body is relative to gravity. Right. So when you're falling forward, let's say, the vestibular system within the inner ear will pick up that forward fall, and it will increase tone in certain areas to keep you upright against gravity. So if you're falling forward, obviously you don't want more flexor tone, you want more extensor tone. So the vestibular system will allow for a reflexive change in extensor tone to upregulate the system and upregulate the extensor tissues to keep you upright against gravity. Right? Because if you're falling forward, sometimes consciously trying to correct yourself isn't fast enough. Right? So these systems are more reflexive. They're operating without our conscious awareness. But they need to handle stress just like other structures as well. So if you think of like your eye, like your shoulder, your eyes have muscles too that need to be able to move through a full range of motion. But very, very often we don't take our eyes through a full range of motion. Yeah. Right. So those structures, like if you think of the muscles around the extraocular muscles, like normal muscles, which they are obviously do have a little bit of a difference kind of architecture and morphology in nature, but they need to lengthen and shorten just like any other muscle. So if you're not lengthening and shortening the muscles around the eyes, then that's going to have an influence on the neck as well, because you have direct connections between the eyes and the neck. So when I look to the left with my eyes, that will facilitate a little bit of a tone in the left posterior side of my neck to prepare me to move to the left. Right, and that's through a neurological tract called your spinotectal tract. So the spinotectal tract will take the information from the eyes and change the tone in the spine in response to the movement of the eyes. So sometimes you can feel this yourself, like if you get the pads of your fingers on the base of the occiput in the suboccipital tissues, and you gently place them there and just apply a little bit of gentle pressure up and under the occiput, and you move the eyes left and right, you'll actually feel a change in tone in those tissues there underneath your finger pads. Yeah. Sometimes, not with everyone.
No, I got it there, yeah, just when I was doing it.
You feel it there, yeah. So that's the spinotectal tract in action. So if your eyes don't move well, think about what's happening then with the ability of the cervical tissues to handle stress. And then think about what happens if the head's not moving well and the vestibular system is not taking on that workload as well. Because with the head and the neck, it's a very, very busy region. You need the eyes to be able to move well to allow for reflexive changes in the head and neck. Because if you don't have that reflexive change, you're probably going to use more of a conscious control mechanism where you're going to hold your neck a little bit more rigid potentially. You're going to keep your shoulders a bit more rigid potentially, if these reflexive, more subconscious systems aren't handling stress. Okay, so we would look at the eyes in the inner ear as a part of the midline region. And so if you have a client with, lots of rigidity around the spine, sometimes especially if they have a history of concussions or if they don't move their body in various ways. The visual and vestibular system may not be able to handle stress very well either. And so the individual will use more of a conscious stiffening strategy of the spine. You'll almost always see that in clients that have vertigo, have a true kind of vestibular disruption to their vestibular system. And you'll often see a co-contraction of the spinal tissues in response to that, because the vestibular system isn't allowing for that reflexive change in tone in the body subconsciously. So the individual has to use a more consciously generated strategy to control the spine. And so they will do that typically by just creating more rigidity around the spine. So it's looking at more things from a top-down perspective. Obviously, the ribcage, spine, pelvis all need to share stress physically, but the eyes and the inner ear also have to manage stress as well to allow for an appropriate amount of tone and tension throughout the midline. Right?
Okay. Yeah. Okay. Yep. That I
obviously that we never we just scrape the surface there, but
yeah,
like when it comes to the rehabilitating those areas, you're really just putting a little bit more emphasis on kind of how you manage your gaze stability, where your eyes are looking. Can you move the eyes independent of the head? You might put a bit more emphasis on the directions that you move the head to change the movement of the eyes. Like if I had, like I move my head to the right and my eyes fixated on the target, my eyes are going to relatively move to the left. That's going to lengthen and shorten certain tissues around the eyes. That's going to have an influence on a certain part of the vestibular system. That's going to have an influence down to the thoracic spine as well, because when I move my neck to the right, that's going to have an influence down to the upper thoracic spine as well. So you can actually pair all of these together to say, okay, like if I'm trying to alter how the tone is being expressed throughout the upper trapezius, for example, maybe it's a case where the upper trapezius isn't actually handling stress or the rib cage isn't moving, or maybe it's a case where the eyes and the inner ear aren't moving very well. And it's just keeping a lot of excessive tone in the muscles because there's not this sharing of stress across all those systems. So like anything, like I said, the eyes and the inner ear have to be able to handle stress just like any muscle, any joint. If they can't handle stress, you'll typically see increase in the workload or increase in muscle activity of the muscles as a compensation, if you like. I hate using that word, but as a compensation.
Yeah. Well, no, what I was going to say is that when I said at the start of the podcast, I said that you're way ahead of what everyone are, what they're teaching at the moment. Like, I think that absolutely rang true in the podcast, because a lot of the stuff that you were touching on there is stuff that myself, I've been looking into it. I've been really kind of getting into how you can connect different sensory systems, and then obviously how your beliefs and attitudes and all that are affecting your lifestyle and affecting your pain levels. And I think there's a lot of people who listen to this, whether they be general population or just people who are interested in injury rehab, interested in keeping themselves in the best shape possible, or if they are practitioners as well, will take a lot from that, because there's so much detail in that podcast that I'm going to have to listen to it again probably 2 times over, to be honest, to get into some of the stuff there that we went into. And I don't want to hold you any longer, because I said I wouldn't keep you much longer than 90 minutes. So I'd love to maybe in future down the line to do another one like this that we could talk about a few other things. But really, for today, Ryan, thanks a million for that. That was excellent. I think. No,
thanks for having me. It's been a pleasure.
It was everything was addressed there that I wanted to address, and more and more and more. And I've 3 pages of notes here trying to keep up with stuff. But first off, where can people find you?
Yeah, so if people want to learn more about us, they can go to ikneurology.com. We have lots of online courses. We have hopefully we're going to get back into in-person courses now. We recently switched to online, so we have online level 1, online level 2, and then we have shorter courses that people can access as well through our website. So if you go to the website, you'll come across online courses and the in-person courses that are coming up over the next few months as well. So www.ikneurology.com. We're on Instagram as well if they want to check out some of the posts that we have there. We go into a lot more detail on lots of the topics that we spoke about here.
Yeah, I definitely direct people straight away if you're listening to this now to check that out on Instagram, because a lot of the stuff that we talked about, you have it perfectly articulated in small posts or in picture posts and in infographics and that. And at least that will be a backup for the people, and then go on. And when you're there, you have to go and check out the website, check out those courses. I must sign up to that level 1 course, because it's something that I've always had in the back of my mind to get done. And after this podcast, now it's definitely something that I'll be jumping on board as soon as possible. But that's excellent. Really, really happy with the way that went. Is there anything you want to leave behind, or anything you want to finish up on?
No, I think we went through a lot there. I think I don't want to confuse people too much or give out too much information that, that maybe kind of clouds things. But no, I think the key thing is just, for me anyway, what really changed my approach is just understanding how the dynamics of the nervous system, anatomy, and the environment. Like, if you actually understand how the environment has led to a distinct organization of our anatomy, or literally our human apparatus, like what we walk around in, our muscles, our joints, how they're organized differently, I think that will really help how you organize your treatment interventions as well, but also how you assess clients too. And that, for me, that was the biggest takeaway from a lot of the courses that I took early on as a physio. But like if you go to our Instagram, you go to our website, we have a blog there as well. We have an Insight of the Week that we share every weekend. So we post lots of additional articles and lots of blog posts on lots of, going deeper into a lot of the information that we spoke about there. So definitely check that out if you want to learn more.
Yeah, excellent. Perfect. Okay, so we'll leave it at that. So again, thank you so much, Dr. Ryan Foley, for jumping on the podcast and giving me the time to go through all these things in so much detail. Definitely check that out on Instagram, and check out their website at ikneurology.com. And yeah, that'll be everything from today. So thank you very much, guys, for listening, and thank you, Ryan, for jumping on board.
Thanks again.
Okay, we'll see you all again next week, guys. So guys, that's everything from us today. Thank you so much again for listening in. If you have any questions on anything that we talked about, direct them towards myself or Ryan. And Ryan is, you can either Dr. Ryan Foley on Instagram or Integrated Kinetic Neurology, IKN. And myself is Mobility Tutor. So direct any questions you have, guys, at us, and we will be able to help you out in some way or another. So really, I wanted to come back on here and say this is going to be a podcast I will have to listen back to myself to pick up on to kind of get a better understanding of all the stuff that we talked about, because as you can see, Ryan is a real expert in the field, and he knows what he's talking about, and he really is able to tie it all together and articulate it very well. So it's going to be one I'm going to go back over myself and take down a couple of notes. So hopefully you got picked up a good bit from that. You took down a few notes and you are able to apply it in your own life. But that's everything for me today, guys. Thank you so much again for listening in, and I will chat to you all again at the same time next week. Have a good one.